Hello, thank you for spending time with me today. My name is Weston Vik. I'm a physical therapist and an orthopedic certified specialist. I graduated from the University of Montana physical therapy program in 2014. I then spent 13 months completing a physical therapy orthopedic residency through a combined program including Johns Hopkins Hospital and George Washington University. I have worked at Kootenai Health since 2015. I have worked with Panhandle Health on the Prescription Opioid Solutions team for the last 2 years. I am a member of the American Physical Therapy Association, or APTA. Within the APTA, I am also a member of the Idaho section, the orthopedic section, and of the Pain Special Interest Group. I serve as the North District Chair for the Idaho Physical Therapy Association. My focus today is to highlight the role that non-pharmacological and non-surgical strategies play in preventing opioid use and misuse, specifically in populations experiencing pain. We will discuss a variety of interventions that are not unique or restricted to one profession or provider. Throughout the talk, I will highlight how and when interventions are used by physical therapists. At the end, I will discuss some research highlighting reduced odds of opioid use when patients are seen by physical therapists. I will highlight when this evidence intersects with other disciplines. My training, education, and experience is as a physical therapist. Thus, that is the area with which I am most familiar. The objectives for today's session are as follows. 1. Briefly discuss the opioid epidemic, including national and local trends in opioid prescription and drug overdose death rates. 2. Review current recommendations from the CDC, or the Centers for Disease Control and Prevention, regarding use of non-pharmacological and non-surgical pain management strategies. 3. Outline non-pharmacological and non-surgical strategies to manage pain. And 4. Explore evidence supporting physical therapy's role in preventing and reducing opioid usage. There are citations throughout the presentation and resources. A full bibliography and list of resources mentioned will be made available to you. I would like to take a few minutes at the outset to briefly establish a foundation, including both what opioids are and how they have been used to treat pain. Opium derivatives have been used for thousands of years in one form or another to relieve pain. Modern opioid medications exist to reduce or manage moderate to severe pain. They work by initiating a series of reactions within your body that result in reduction in the sending of pain signals, thus reducing pain. There are 3 main classes of opioids: natural opioids, including morphine and codeine; semi-synthetic, involving hydrocodone and oxycodone. Lastly, there are synthetic drugs including fentanyl and methadone. Historically, these medications were prescribed following episodes of acute pain such as injury or following some surgeries, end-of-life care, and for cancer-related pain. Over the last few decades, opioid prescriptions expanded to be used for chronic, non-cancer pain. However, the current evidence for the effectiveness of opioid therapy on managing chronic pain continues to be limited. You can see here the risks associated with use of opioid medications include addiction, abuse, overdose, and death. I would like to highlight some of the possible side effects, including tolerance, meaning you might need to take more of the medication for the same pain relief. As dosage increases, so do the risks. Tolerance does not go away after the medication is stopped and will impact the dosage required to manage any future pain. Physical dependence, meaning you have symptoms of withdrawal when the medication is stopped. And increased sensitivity to pain, also known as opioid-induced hyperalgesia. This involves heightened sensitization to pain, increasing the amount of pain the person experiences. Though opioids have been used for centuries to manage pain, over the last few decades, significant advances were made in the potency of these medications and the method of delivery. This occurred at the same time there was concern that pain was not being adequately addressed by medical professionals. As mentioned previously, we saw a sudden expansion in the acceptance of opioids being prescribed for chronic non-cancer pain. This includes many conditions such as lower back pain, osteoarthritis, and more. Here are some statistics to help illustrate the rapid increase in prescribing patterns. Starting in 2006, the rate of opioids prescribed in the U.S. drastically increased, reaching a peak in 2012 at a rate of 81.3 prescriptions per 100 persons. The rate then declined gradually until 2020, when it was the lowest it had been in 15 years, at 43.3 prescriptions per 100 persons. Though, in some parts of the country, the rate of prescriptions remains very high. That is the national situation. What is the situation in our region? Here, we have opioid prescription rates per 100 persons for the 5 northern counties provided by Panhandle Health. Despite the opioid prescription rate in northern Idaho gradually decreasing over the last 6 years, the rates continue to be greater than the national average in each of the 5 counties. Despite rates of opioid prescriptions gradually declining, drug overdose deaths involving prescription opioids continue to occur in non-trivial numbers. For example, in 2020, an average of 44 people died each day from overdoses involving prescription opioids, totaling more than 16,000 deaths. Prescription opioids were involved in nearly 18% of all opioid overdose deaths in 2020, with over a 16% increase in prescription opioid-involved death rates from 2019 to 2020. The overdose deaths associated with the epidemic involve 3 phases. First, with prescription opioids, then with heroin, and now we are experiencing the third wave involving fentanyl. Fentanyl is a synthetic opioid created and approved to treat severe pain. It's 50 to 100 times more potent than morphine. Unfortunately, illegally made fentanyl is very common. Also, fentanyl can be mixed with other drugs such as heroin and cocaine, often unbeknownst to the individual obtaining and using the drugs. Deaths involving synthetic opioids have been on the rise over the last few years, and early data indicates an acceleration of these deaths during the COVID-19 pandemic. Locally, we have seen increases in fentanyl-involved overdoses as well. In response to the mounting opioid-related overdose deaths, the Centers for Disease Control and Prevention, or CDC, developed the CDC Guidelines for Prescribing Opioids for Chronic Pain, United States, 2016. They provided guidance on opioid prescribing for chronic pain in adult outpatient settings, excluding cancer, palliative, and end-of-life care, to ensure safe and effective pain management while reducing risk and harm. I have pulled a few statements highlighting support for the use of non-opioid pain management strategies. The first recommendation reads, quote, "Non-pharmacologic therapy and non-opioid pharmacologic therapy are preferred for chronic pain," end quote. The next passage highlights that non-pharmacological therapies, including physical therapy and psychological therapies, including cognitive behavioral therapies, or CBT, can ameliorate chronic pain. Lastly, it highlights that strategies including exercise and CBT should be used to reduce pain and improve function in patients with chronic pain. A draft revision of these guidelines recently ended its period for public comment, and a final version will be published in the near future. The revision utilized best available scientific evidence and input from community partners. The following recommendations remain consistent from the original 2016 guideline and the current 2022 draft revision. The highlighted sections of the revision state that non-opioid therapies are preferred for subacute and chronic pain. It also states non-opioid therapies are effective for many common types of acute pain, and there continues to be insufficient evidence to determine long-term benefits of opioid therapy for chronic pain. It is worth stating that opioids can be a safe and effective part of a comprehensive pain management strategy. An often used condensed quote by Paracelsus reads, quote, "The dose makes the poison," end quote. This applies to opioid medications. During the height of the opioid crisis, opioids were overutilized for chronic non-cancer pain with inadequate evidence of efficacy and safety. Now, there is ample evidence that there is significant risk of harm, but relatively little evidence of efficacy. Our goal is to promote forms of pain management that are both effective and evidence-based without the side effects, risk of addictions, and adverse effects associated with opioids. In addition to these guidelines, we have data from a poll suggesting that people in the United States may prefer alternatives to opioids to manage their pain. In the 2017 Gallup-Palmer College of Chiropractic annual report, Americans' Views of Prescription Pain Medications and Chiropractic Care, a poll including just over 6,000 people found the following, quote, "When asked which of the following best describes you, 78% reported, 'I prefer to try other ways to address physical pain before I take pain medication prescribed by a doctor,' end quote. This seems to make our task fairly easy. There's evidence supporting non-pharmacological and non-surgical strategies to manage pain, and polling data suggests public interest in alternatives to prescription medication to address physical pain. Let us broadly explore the strategies available to prevent and manage pain. Since pain is the elephant in the room that we are trying to address, let's start there. Defining what pain is and how it works will set a great foundation for how we go about addressing it. The International Association for the Study of Pain recently updated the definition of pain. They define pain as follows, quote, an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage, end quote, and is expanded upon by the addition of 6 key notes and etymology of the word pain for further valuable context. 1. Pain is always a subjective experience that is influenced to varying degrees by biological, psychological, and social factors. 2. Pain and nociception are different phenomena. The experience of pain cannot be reduced to activity in sensory pathways. 3. Through their life experiences, individuals learn the concept of pain and its applications. 4. A person's report of an experience as pain should be accepted as such and respected. 5. Although pain usually serves an adaptive role, it may have adverse effects on function and social and psychological well-being. 6. Verbal description is only one of several behaviors to express pain. Inability to communicate does not negate the possibility that a human or a non-human animal experiences pain. The aspects of this definition that stand out to me include the following. Pain is an experience, not just a sensation or feeling. Further, pain does not mean tissue has been damaged. It is more complex, including both emotional and sensory components. The threat of tissue damage can lead to pain without any tissue disruption occurring. Please keep this definition of pain in mind as we continue. The pain management strategies highlighted and discussed today will include the following: pain neuroscience education, education regarding medical imaging, physical activity or exercise, sleep, nutrition, and finally, mental health and stress management. Pain neuroscience education. Simply put, pain neuroscience education, or PNE, is teaching people about pain biology and physiology to reconceptualize their understanding of pain to make it less threatening. This involves expressing to individuals why they hurt with explanations based in modern pain science, educating patients that pain is a product of the nervous system designed to protect tissues from harm that is determined by multiple processes and inputs. This reflects the modern definition of pain we reviewed. I like this quote by Dr. Paul Minkin, a physical therapist. Quote, "We need to educate our patients that the biology of pain is never straightforward, and that pain does not provide a window into the state of the tissues and is frequently modulated by psychosocial and somatic factors. As pain becomes persistent, the relationship between the tissues and pain is less predictable, and pain becomes an output based on the brain's perception of tissue danger." End quote. Recent systematic reviews have found that PNE, when provided alone, does not have a significant effect on pain or disability. PNE is intended to fit into a biopsychosocial framework to complement other multimodal interventions. It is not intended as a standalone intervention. For example, it can be an adjunct to promote exercise and movement. These reviews did find that PNE does produce clinically significant reductions in both kinesiophobia, which is fear related to movement or physical activity, and pain catastrophization, which is, quote, characterized by feelings of helplessness, active rumination, and excessive magnification of cognitions and feelings towards the painful situation, end quote. If kinesiophobia or pain catastrophization is present, they could be significant barriers to individuals participating in active self-management of pain. PNE can facilitate individuals' ability to cope with their condition. What role can physical therapy play? Well, physical therapists can provide pain neuroscience education as an adjunct to other treatments to reduce fear related to their symptoms and movement, help them feel safe to increase their activity through exercise, work, social interaction, or activities of daily living. I have included a brief list of video resources with links. We will not be able to view these today, but I encourage you to explore them if you would like to learn more about this topic. Next, I have a list of individuals that perform research and provide education in this field of study. There are many more out there. P&E can be provided in multiple formats tailored to patients and/or clinicians. Patient education about imaging. Medical imaging serves an important role in diagnosis, prognosis, and treatment selection. MRI findings can lead to further medical expenditures and treatments based on the image. There is little available evidence on public and patient beliefs about imaging. But one article that did examine this is a recent scoping systematic review by Taylor and colleagues that found that in management of nonspecific lower back pain, patients view imaging positively. This is driven by a desire for a diagnosis. However, abnormal MRI findings are common in asymptomatic populations and increasingly common with age. This includes bulging discs and disc degeneration in the lumbar spine, disc bulges in the cervical spine, superior labral tears in the shoulder, labral injury in the hip, and both knee arthritic changes and knee meniscal tears. Many conditions associated with MRI findings treated with active rehabilitation or placebo surgery have similar long-term outcomes compared to surgical treatments. Examples include subacromial impingement, lumbar degenerative disc disease, knee meniscal tears, and hip femoroacetabular impingement syndrome. How can we reduce increased fear, medical costs, and unnecessary procedures? Well, we can utilize accepted guidelines for medical imaging to avoid both under- and overutilization, use clear language when discussing imaging findings to reduce harm or unnecessary procedures, place in context of normal imaging findings, such as normal age-related changes, correlate findings with clinical signs and symptoms. The complexity of the pain experience should be considered when reviewing imaging findings. As discussed before, pain does not equal tissue damage. This concept is reflected in 1, how common abnormal imaging findings are in asymptomatic individuals, and 2, in many diagnoses that involve abnormal imaging, long-term outcomes are similar between conservative and surgical interventions. What role can physical therapy play? We can aid in screening to determine if medical imaging is warranted, review imaging findings with patients with clear language, outlining what may be asymptomatic findings versus significant pathology requiring further assessment or invasive treatments, stressing the importance of correlation of findings with clinical presentation, ideally reducing unwarranted fear, stigma, and self-limiting behavior. One resource that I would like to highlight are the American College of Radiology appropriateness criteria for imaging, which are, quote, evidence-based guidelines to assist referring physicians and other providers in making the most appropriate imaging or treatment decision for a specific clinical condition, end quote. Let's turn our attention to nutrition and its role in comprehensive pain management strategy. An individual's nutrition has many impacts on their overall health. There are also many unique and varied beliefs about the best way to approach nutrition. A common agreement is that food and nutrition play a vital part in both health promotion and the prevention of chronic diseases, specifically diabetes, cardiovascular disorders, and some cancers. There is a growing body of research examining the relationship between chronic musculoskeletal pain and the most effective nutrition-based interventions to address chronic pain. A 2018 systematic review by Brain and colleagues examined the impact of nutrition interventions on participant-reported pain severity and intensity in populations with chronic pain. They found that nutrition interventions did have a significant effect on pain reduction. They found studies testing an altered overall diet or just one nutrient having the greatest effect. We have established the important role nutrition plays. How well do Americans do related to established guidelines? The CDC released a report in January of 2022 with the results of a survey of the United States on their regular fruit and vegetable consumption. In 2019, 12.3% of surveyed adults met the fruit recommendations and only 10% met the vegetable recommendations. So, what resources are available to help both patients and providers? The U.S. Department of Agriculture, with the Health and Human Services, partner to continuously update and release the dietary guidelines for Americans in 5-year intervals. The most recent edition covers 2020 to 2025. The focus is on both health promotion and disease prevention when developing these guidelines. The webpage has a variety of resources, materials, and tools to help consumers use the guidelines. The guidelines are intended to provide a framework that can be adapted to individual-based factors, including personal, cultural, and traditional preferences. What role can physical therapy play? Well, physical therapists can screen individuals to learn about their overall health, diet, and nutrition to facilitate optimal recovery. Physical therapists can also provide education, support behavioral changes relative to diet and nutrition, and refer or collaborate with registered dietitians, nutritionists, or other specialists when warranted. Sleep. Next, we will explore sleep. Sleep is an integral part of life. Getting adequate amounts of and quality of sleep can positively impact overall health, well-being, and be restorative. Sleep is critical for immune function, cardiovascular health, cognitive function, and learning and memory. Not getting the necessary amount of sleep or experiencing poor quality or disrupted sleep can have negative impacts ranging from small to large, including increased pain perception. The current consensus is that adults require 7 or more hours of sleep each night for the best health and well-being. However, the CDC highlights that a third of U.S. adults report usually getting less than the amount of sleep recommended. Not getting enough sleep is linked with many chronic diseases and conditions. The prevalence of short sleep duration, meaning less than 7 hours, in working American adults increased from 30.9% in 2010 to 35.6% in 2018 per findings from National Health Interview Surveys. Most related to our talk today, there is a bi-directional relationship between sleep and pain. Simply put, the quality and amount of sleep someone experiences can impact their pain. And if someone is in pain, it can impact the quality and amount of their sleep. In addition, sleep disturbances have been linked to cardiovascular health and are very common in individuals with anxiety and depression. Sleep quality can be assessed by healthcare providers with a few questions and/or use of freely available screening tools to screen for the most common sleep disorders. Here is a list of general questions that can be asked. How much sleep do you typically get? Do you feel rested when you wake up? Is your condition impacting your sleep? If so, how? How would you rate your sleep quality? Does being sleepy during the day interfere with your daily function? Do you have difficulty falling asleep? Difficulty returning to sleep if you wake up in the middle of the night? Or difficulty with waking up too early? If this is present for greater than 3 months, it is a possible indication of insomnia. Do you snore loudly or frequently? Has anyone observed you stop breathing while you sleep? This could be a possible indicator of obstructive sleep apnea. Do you have a strong urge to continually move your legs while you are trying to sleep? This could be a possible indicator of restless leg syndrome. Further screening for common sleep disorders, when indicated and appropriate, can be helpful. The 3 most common sleep disorders experienced by Americans are insomnia, obstructive sleep apnea, and restless leg syndrome. Here I have listed examples of screening tools for each disorder. If a significant sleep disturbance or sleep disorder is suspected, then referral for additional evaluation and treatment may be warranted. Evaluation could include interviews, sleep studies, or more, and possible interventions include medical devices or medications or other possible interventions. Common interventions for insomnia and sleep disturbances include education on sleep hygiene or cognitive behavioral therapy for insomnia. Sleep hygiene is, quote, a set of instructions to modify behaviors or the environment that promotes sleep, end quote. And cognitive behavioral therapy for insomnia is, quote, a structured program that helps you identify and replace thoughts and behaviors that cause or worsen sleep problems with habits that promote sound sleep, end quote. The goal is to improve the quality and quantity of sleep. It involves cognitive and behavioral components. Here are examples of sleep hygiene instructions. Go to sleep and wake up at the same time every day. Use your bed for only sleep and sexual activity to help train your brain that if you are in bed, you should be sleeping. Do not take unprescribed or over-the-counter sleeping pills. Avoid daytime napping so that you are tired at night and can fall asleep easily. Make your sleeping environment comfortable and relaxing. Avoid moderate to vigorous exercise at least 2 to 3 hours before bedtime. Avoid caffeinated foods and drinks at least 4 hours before bedtime. Refrain from drinking alcohol or smoking at least 3 to 4 hours before bedtime. Develop a relaxing bedtime routine. Avoid eating a large meal or spicy food 2 to 3 hours before going to bed. Now, let's look at cognitive behavioral therapy for insomnia. The cognitive component involves identifying and changing beliefs that affect the ability to sleep, managing or removing negative thoughts that prevent sleep. The behavioral component involves creating positive sleep habits and reducing behaviors that prevent individuals from sleeping well. Tools include sleep hygiene, relaxation training, stimulus control, improving the sleep environment, and more. This can be provided in person by trained providers. There are a growing amount of resources such as online courses or books that provide instructions to individuals interested in participating in CBTI. What role can physical therapists play? Physical therapists can include assessment of sleep health, including screening for sleep disorders. If a sleep disorder is suspected, they can refer for further assessment. PTs can also educate on sleep hygiene, provide an exercise program to aid in sleep, explore positioning to promote improved quality of sleep, and address any bed mobility issues that may be present. Here, I have included a list of links to websites that are excellent resources for further exploration of sleep and its role in overall health and well-being. Exercise and physical activity. Physical activity or exercise has an incredible effect on overall health, well-being, and function. The positive effects of being physically active for kids, adults, older adults, and those living with chronic health conditions are numerous. Adequate physical activity has been shown to both aid in preventing development of chronic health conditions and a strong role in managing chronic conditions. For those living with chronic health conditions, appropriate and adequate exercise can improve quality of life, function, and mobility. Here are a few other examples of the benefits of adequate physical activity. Specifically related to this talk, exercise has been shown to have a strong role in aiding in managing pain both directly and indirectly. Directly, there is a growing body of evidence for exercise-induced hypoalgesia. Simply put, doing an adequate amount and intensity of exercise will result in the brain releasing substances to reduce pain. Recent systematic review by Wawegi and Jones suggests that a, quote, single bout of aerobic exercise reduces experimental pain in healthy individuals, end quote. Another recent systematic review by Tan and colleagues found, quote, evidence that aerobic exercise reduces pain sensitization in individuals with musculoskeletal pain, end quote. Further research is needed to determine if these findings apply to populations with chronic pain, the specific dose response, including the type and amount of exercise, and if there is an impact on quality of life, disability, or outcomes. Indirectly, exercise can address many factors that influence the pain experience. Exercise can reduce anxiety and depression, aid in management of chronic diseases, and improve the quality and duration of sleep, which all have an impact on pain. So, we have established that physical activity is helpful, but how much do we need? Well, like most things, this will vary. But we do have guidelines to serve as a starting point. In 2020, the World Health Organization released guidelines on physical activity and sedentary behavior for adults aged 18 to 64 years, including those with chronic conditions and those living with disability. All adults should undertake regular physical activity. Adults should do at least 150 to 300 minutes of moderate intensity aerobic physical activity, or at least 75 to 150 minutes of vigorous intensity aerobic physical activity, or an equivalent combination of moderate intensity and vigorous activity throughout the week for substantial health benefits. Also, adults should also do muscle strengthening activities at moderate or greater intensity that involve all major muscle groups on 2 or more days a week, as these provide additional health benefits. There are guidelines specific for children ages 5 to 17, older adults, or adults over age 64, and for pregnant and postpartum women. One change in this version is the move away from a minimum activity level, but specifying that any duration of physical activity counts towards the recommendations. The previous guidelines stated that bouts of activity had to be at least 10 minutes. I feel this is important to highlight. Any progress towards increased physical activity should be recognized and encouraged. Many individuals, due to mobility issues, chronic health conditions, or baseline fitness, may not be able to sustain 10 minutes of moderate physical activity. Now that we know the suggested amount of physical activity, how do we do? Well, per the World Health Organization, globally, 1 in 4 adults do not meet the global recommended levels of physical activity, and more than 80% of the world's adolescent population is insufficiently physically active. Per early release of 2018 National Health Interview Survey, 53% of adults over 18 meet the physical activity guideline for aerobic physical activity. Only 23.2% met the physical activity guidelines for both muscle strengthening and aerobic activity. You'll see here I have listed 2 resources. First are the physical activity guidelines for Americans, and second are the World Health Organization guidelines for physical activity and sedentary behavior. What role can physical therapists play? Well, exercise is a core intervention used by physical therapists for rehabilitation. We develop, provide, and adapt exercise programs to address relevant strength, mobility, or endurance deficits to address activity limitations, promote optimal function, and reduce acute and/or chronic pain. Mental health. Now we turn our attention to mental health and its possible relationship to chronic pain. Mental health is an umbrella term that includes our emotional, psychological, and social well-being. Both chronic pain and mental health disorders, such as depression and anxiety, are common in the general public. Recent studies have suggested a bi-directional relationship between behavioral health disorders and chronic pain. Emerging evidence indicates part of the reason for this bi-directional relationship is that both share neural mechanisms. An indirect relationship between mental health and chronic pain exists as well. Anxiety and depression can negatively impact sleep, reduce motivation to be physically active, and/or reduce the motivation for food shopping, meal planning, or cooking. We have already highlighted that sleep, physical activity, and nutrition influence pain as well. As mentioned above, mental health includes social well-being. The World Health Organization defines social determinants of health as, quote, the non-medical factors that influence health outcomes. They are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life, end quote. Examples include income, education, housing, employment, access to healthcare, early childhood development, discrimination, and more, end quote. An area receiving more attention is the role that adverse childhood experiences, or ACEs, play in a variety of health outcomes in childhood and adulthood. Examples of ACEs include experiencing physical, emotional, or sexual abuse, witnessing violence in the home, having a family member attempt or die by suicide, growing up in a household with substance use, mental health problems, or instability due to parental separation, divorce, or incarceration. A recent study by Groenwald and Collings found that, quote, children and adolescents with ACEs had increased risk for chronic pain, and this association increased in a dose-dependent fashion, end quote. There are many screening tools for many of the discussed conditions that are both evidence-based and easy to use. I have included a list of screening tools for the following conditions. For anxiety disorder, the Generalized Anxiety Disorder 7, for depression, the Patient Health Questionnaire 2 or 9, and for adverse childhood experiences, the Adverse Childhood Experiences Questionnaire. These tools can help to screen for the above disorders and experiences. However, these tools are not diagnostic. Please refer to the appropriate professional and provider as needed. What role can physical therapy play? Physical therapists can screen for the presence of these conditions. If identified, they can refer to the appropriate healthcare professional for treatment. When appropriate, they can collaborate with the specialist to facilitate optimal outcomes. So, how often are opioids prescribed compared to the alternatives? In this study, data from a United States cross-sectional survey was used to explore clinical management of new cases of musculoskeletal pain that was likely chronic. Just under 12,000 visits were assessed spanning a period of 9 years. Findings revealed the following specific proportions of prescriptions. 21.5% were prescribed opioids, 11.7% were prescribed exercise counseling, 10% were prescribed physical therapy, and 0.4% were prescribed mental health counseling, and 0.14% were prescribed psychotherapy. Odds ratios will be used to discuss the following papers. A brief primer on odds ratios. Quote, an odds ratio represents the odds an outcome will occur given a particular exposure compared to the odds of the outcome occurring in the absence of that exposure. Essentially, an odds ratio less than 1 means exposure is linked to reduced odds of an outcome. And odds ratio greater than 1 means exposure is linked to increased odds of an outcome. I want to discuss a review article titled Physical Therapy and Opioid Use for Musculoskeletal Pain Management, Competitors or Companions? Published in 2020 in the journal Pain Reports. As part of their review, they abstracted adjusted data reported from observational studies that have examined early exposure to physical therapy with subsequent opioid prescriptions. The authors used reported odds ratios and 95% confidence intervals for these estimates. As indicated in the quoted portion, all are adjusted estimates unless otherwise specified. The odds ratios from these studies were consistently below 1 for lower back pain, neck pain, shoulder pain, knee pain, and persistent musculoskeletal pain, indicating a reduced likelihood of opioid prescriptions associated with early exposure to physical therapy. The majority of the studies were of observational design involving secondary analyses of claims or registry data and may not account for potential biases. The next article we will discuss is titled Observational Retrospective Study of the Association of Initial Healthcare Provider for New Onset Low Back Pain with Early and Long-Term Opioid Use. It was published in 2019 in the BMJ. This article reviewed just over 200,000 cases. This analysis showed substantially decreased long and short-term opioid use associated with initial visits to chiropractors, acupuncturists, and physical therapists for new onset of lower back pain. The final pair of studies I would like to look at examined physician practice patterns using United States National Survey data from 1997 to 2009. The first study, titled Trends in Ambulatory Physician Opioid Prescription in the United States 1997 to 2009. They examined the changing practice patterns of prescribing opioids in 3 ambulatory settings. They found that the odds of receiving an opioid medication prescription for back pain increased every 5 years by 35% in emergency departments, by 38% in primary care physician clinics, and by 75% in specialist clinics. The second study, titled Stagnant Physical Therapy Referral Rates Alongside Rising Opioid Prescription Rates in Patients with Low Back Pain in the United States 1997-2010. This study utilized the same national survey data to determine trends of physical therapy referral for lower back pain at primary care physician visits. Results revealed physical therapy referrals remained stable around 10% as opioid prescription rates steadily increased. Patients not referred to physical therapy were more likely to receive an opioid prescription and had an odds ratio of 1.69. While, when physical therapy was prescribed at the same visit, they found reduced odds of opioid prescription and had an odds ratio of 0.57, indicating lower likelihood of a prescription. These studies are relatively old now, but they do highlight referral trends during the beginning of the opioid crisis. Trends of increasing referral for opioids compared to relatively stagnant referrals to an alternative management strategy. In summary, locally, opioids continue to be used at a high rate to manage pain, and overdose deaths related to opioid use continue to occur both locally and nationally. Some evidence suggests Americans are interested in pain management strategies outside of prescription pain medication. Non-pharmacological and non-surgical pain management strategies are effective and recommended to address chronic pain. Pain is multidimensional and complex, influenced by many factors including but not limited to our mental health, sleep health, nutrition, and physical activity. Available information suggests that many Americans do not meet established recommendations for nutrition, sleep, and physical activity. Evidence suggests that opioids have historically been prescribed more than alternative treatments, including exercise therapy, mental health therapy, and physical therapy. Evidence exists that early exposure to physical therapy is associated with lower odds of opioid use. Again, the interventions discussed are not unique or restricted to one profession or one provider. Addressing opioid-related issues, both local and national, will take collaboration involving the entire community, professional and otherwise. Considerations. Please consider referral for non-pharmacological and non-surgical services when appropriate for the population you serve. Please consider the variety of treatments and psychosocial domains that can be addressed to manage pain, including but not limited to mental health, physical activity, nutrition, sleep health, and mobility. And finally, please consider employing a multidisciplinary approach when able to provide comprehensive treatment to not only manage pain, but to identify and address the cause of pain. Thank you very much for your time today.